In this episode of Tea Time, we explore how Rescue TEE is transforming cardiac arrest management, both in and out of the operating room during code situations. We'll also cover clinical outcomes and hospital implementation tips as we break down what every provider needs to know when seconds count. Welcome back to Tea Time. I'm your host, Dr. Andreas Plakis, and in this episode 17, we're going to cover Rescue TEE, Everything You Need to Know, Part 3 of our 3-part series. In previous episodes, we've covered both Part 1, the Tea Time Rescue TEE protocol, and Part 2, Common Diagnoses and Shock States. Part 3, this episode, we're going to review cardiac arrest considerations, clinical applications, outcomes, limitations, and logistics. We do have a free resource available for you we introduced in the prior 2 episodes, the Tea Time Rescue TEE protocol. This is an incredibly high-yield 2-page document that's available at no cost for you. All you have to do is either leave us a review or hit the like button, write in the comments something you like about this show, and make sure you leave your email address, and then we'll send you this document that you can use either electronically, you can print it out or laminate it, but this is available for you if you follow those steps. I want to briefly review what was covered in the prior 2 episodes. In episode 15, we introduced the Tea Time Rescue TEE protocol. Now, this consisted of 3 steps. Step 1, seen here, was the initial Rescue TEE evaluation. This is where when you're evaluating a patient, you perform a mid-esophageal 4-chamber view, a mid-esophageal long-axis view, and a transgastric mid-short-axis view. In each of these views, you're going to be looking in the heart, at the heart, and around the heart to discern if there's a problem with preload, contractility, or afterload. Step 2 will be your targeted follow-up assessment, where we differentiate the shock component that was identified in Step 1. This is where you further delineate what the cause of abnormal preload is, of abnormal contractility, or abnormal afterload. Step 3 is where you perform a complete basic exam and any other indicated views, evaluating left-sided, right-sided structures, going into the stomach, turning towards the aorta and back to the pulmonary artery, and then evaluating any other special features. This is the most comprehensive part of the exam to make sure you didn't miss anything and further solidify your diagnosis and get to the next step of tailoring your management from there. In Tea Time episode 16, which was the part 2 episode of this series, we went over all these different causes of hemodynamic instability and what they may present like with a Rescue TEE exam, going through the categories of preload, contractility, afterload, rate, rhythm. We saw a bunch of these different examples. Now we're going to focus our attention on Rescue TEE and its use in cardiac arrest management. Anytime a patient has cardiac arrest, there's always 4 things that I want to make sure I ask for every single time. These are echocardiography, vitals and monitors, labs, and then getting a very focused history. As far as echocardiography, I want to make sure I either have a TEE or TTE available. Regarding monitors and vitals, that we make sure we check the rate, rhythm, oxygen values like a pulse ox, temperature, end-tidal CO2. For lab values, looking at an ABG and blood gas analysis, electrolytes such as sodium, potassium, magnesium, calcium, glucose, and then hemoglobin. And then regarding history, asking what were the most recent medical and surgical events that happened in the last 20 minutes or so that could have contributed to this arrest. The part of this management we're focusing on in this episode is echocardiography and how it plays a crucial role in differentiating some of these causes of cardiac arrest. So what are some of the advantages of using TEE compared to TTE when it comes to cardiac arrest management? Well, first off, I will choose TEE 100% of the time if it is available because of some of these clear advantages that are seen, unless there are absolute contraindications present. Some of the advantages to TEE are that you can continue chest compressions while you're using it, whereas you may have to stop or have disruption of them to get TTE views because both are performed on the chest. TEE allows for continuous hands-free monitoring where once you get a view, you can leave the probe in that position and continue to monitor the heart while you're doing other things with your hands. TEE is very useful for different procedural guidance. Oftentimes, there's better diagnostic ability and superior image quality, especially in patients who have high BMI, open chest or chest wall injuries, recent sternotomies, or certain exterior obstacles. You can see some of these views where in the TTE image, you may have a grainy image where you can't make any definitive diagnostic assessments, but with TEE, it's very common to get a very clear image and not have to worry about optimizing your view significantly. Some of the downsides of using TEE, it's slightly more invasive, and it's also also slightly less available, so it's harder to get your hands on and sometimes even harder to get to remote settings. When it comes to using TEE during cardiac arrest, there's three major benefits that I think of. The ability to delineate arrhythmias, so discerning between true versus pseudo PEA, the ability to improve CPR and specifically improve either the depth or location of the chest compressions. And then number three is return of spontaneous circulation identification. How is TEE useful in evaluating arrhythmias during cardiac arrest management? Something that's important to differentiate between is true pulseless electrical activity or PEA versus pseudo PEA. True PEA is defined as the absence of ventricular contraction despite the presence of electrical activity. Pseudo PEA, that's the presence of ventricular contraction in patients without palpable pulses. And the reason these matter is because pseudo PEA can be of diagnostic and prognostic importance. Patients that arrive to an ED with cardiac standstill have less than 1% chance of survival to hospital discharge. So it can provide information into the contractile state that can't be differentiated with EKG, but you can see the amount of ventricular contraction on echo. Additionally, you can notice some of these other contractile states, such as VTAC or VFib, where you see these inadequate quick contractions that are inadequate to create a pulse, but also indicate that there may be some rhythm that is shockable at that time. This is not meant to replace EKG, but to further supplement it and adding diagnostic significance to your arrhythmia evaluation. When it comes to CPR quality, there are two main goals of chest compressions. Number one, ensuring there is maximal compression of the left ventricle, and number two, making sure there is opening of the aortic valve, as chest compressions where there's opening of that aortic valve are associated with increased return of spontaneous circulation. Now, TEE can be useful to guide both CPR depth and location to ensure that these two goals for high-quality compressions are met. When it comes to CPR depth, you can see in these echo clips that the left ventricle is being compressed in that top echo clip. That is what we want when we have chest compressions. However, when we're having inadequate compressions, you can see that there's inadequate depth that isn't hardly compressing that left ventricle, so you're not getting systemic ejection of blood flow that you would want in high-quality CPR. When it comes to the location of CPR that's being performed, the left ventricle can actually vary in size and location in different patients, depending on the size and shape of the heart or the chest wall anatomy. Poor CPR is where you're not getting good left ventricular contraction, where you could be only compressing the right ventricle, or you're inappropriately compressing the LVOT or aortic valve, essentially stopping ejection of blood flow from the heart by compressing those regions. When you look at good high-quality CPR, you want to see it compressing the left ventricle and not compressing the LVOT or aortic valve, which has been seen in up to 50 or 60% of cases. So if a patient is undergoing CPR, you can use TEE to actually guide the optimal chest compression location to ensure that they're just compressing the left ventricle. Lastly, when it comes to cardiac arrest management, we'll see factors that help us differentiate when return of spontaneous circulation or ROSC has occurred. Some of the characteristics of ROSC that you may see with TEE include left ventricular ejection. This is where you have coordinated wall thickening and also the cavity size of the LV getting smaller when it contracts. You'll see aortic valve opening, and this correlates with stroke volume because if the aortic valve does not open, that means you have no cardiac output to open it. You'll see mitral valve motion as well, where you have diastolic opening and systolic closure of the valve. And then if you evaluate the descending aorta, you'll see true systemic flow there if you evaluate this with Doppler. This comes into play when sometimes you're trying to differentiate if you have ROSC versus you're just checking pulse with a hand and you're not sure if you feel one or not. This can give you an additional tool to let you know if there's cardiac function or not, because if you see the heart in the top echo clip, you'll know that you do not have return of spontaneous circulation as you see no ventricular contractions. Or if you have this heart in the bottom picture, it will give you more confidence that you have cardiac output that could be contributing to a pulse that you're feeling. Now, what are some of the clinical tips regarding using Rescue TEE? The first clinical tip is being aware of satisfaction of search error. This is where you're looking for the problem, you find your initial diagnosis, and then you stop looking for others. In Rescue TEE, you can have multiple problems at the same time, so don't stop performing your exam when you find one finding. The next tip I'll offer is thinking through your rate-limiting steps. Your goal is to be as quick as you can from decision to perform echo to landing on a diagnosis. So you need to think through what the steps are that can get you your answer as quickly as possible. Get your equipment to the room, get the right personnel to the room. This is one people don't think about a lot, but make sure the machine power on button is hit as soon as possible, whether it's you turning it on or someone who's calling you to come to the room for echo turns it on, because oftentimes the rate limiting step is the 2 to 3 minutes it takes an echo machine to boot up. So you don't want to be sitting there during an emergency waiting on a technical issue when it could be avoided. Your goal is to have an answer within 30 seconds and ideally within 20 seconds of performing this exam. You want to be quick, so you want to think through all the steps that can get you your answer as quickly as possible. Another tip is always perform all 3 steps of this exam. If ever the patient status changes, perform all 3 steps over again. This helps limit that satisfaction of search error where you land on an initial diagnosis and you miss other things. Be systematic about it. There's a reason we have 3 steps to this exam, and they need to be performed every single time. Lastly, one thing I would recommend you do if you really want to be elite at this and you have not had as much experience, practice with simulators or actual visualization, even on your own. You want to have your system down very, very well before you get in emergencies. And if you can visualize it in your head just the same way a pro athlete would visualize their swing or a jump shot, you want to make sure you can see exactly the way that you would go through the system in the exam and how you would conduct yourself in an emergency. So when it comes time to actually take care of a patient, you know what you're going to be doing ahead of time. So how has Rescue TEE influenced clinical care, especially in the non-cardiac operating room setting? Some of the ways it can influence clinical care are causing a provider to give more fluids, vasopressors, inotropes, a new or altered procedure, canceling the case, escalating care to an ICU admission. There were a couple major studies. There was a retrospective review in 2015 that evaluated 364 patients that reported it changed management in 59% of cases. And there was an even larger systematic review in 2018 with 558 patients that reported there was a change in management for patients that had Rescue TEE in up to 81% of these cases. But based on some of these findings, it does make a significant clinical difference when it's used in emergencies. Should TEE be used more commonly in trauma bays or trauma operating rooms? Some of the pathology you may see in these settings are a pericardial or pleural effusion, traumatic aortic injuries, penetrating injuries, hemothorax, blunt ventricular trauma, or even hypovolemia. Well, one study looked at this in 2022 as a retrospective review of 171 patients that had Rescue TEE and then a little over 4,000 patients that had traditional hemodynamic monitoring. The reported findings here were that patients who had Rescue TEE had a 7% in-hospital mortality compared to 23.6% that had traditional hemodynamic monitoring. Because this was a retrospective review, causation obviously can't be established, but it is an important signal that there may be significant benefit to Rescue TEE in this patient population. It also supports the utility of having Rescue TEE in addition to traditional invasive hemodynamic monitoring in trauma settings. Keep in mind that you need to use extreme caution or even avoid TEE in patients who have penetrating neck or chest injuries as you worry about esophageal injury or penetrating upper abdominal injuries where the patient could have gastric injuries. Also, a relative contraindication to TEE are cervical spine injuries that have not been cleared. Let's talk about some of the training or credentialing requirements needed to use Rescue TEE. There are no formal guidelines on training or credentialing to be able to use Rescue TEE, but there are some society recommendations. The ASA in 2022 had a statement on perioperative TEE where they recommended only physicians with appropriate training in perioperative TEE and who have been credentialed for perioperative TEE by their institution should consider using it. This is where you have either basic or advanced perioperative transesophageal echo certification or hospital credentialing. Also, the American College of Emergency Physicians have a program that recommends 2 to 4 hours of training, 10 supervised TEE exams, and then a formal assessment after that. There should be extreme caution if someone is not adequately trained to both perform TEE and interpret images. Bad information can be worse than none at all. The risk here is that with these simplified imaging protocols, it can produce overconfident providers. Unfortunately, I've seen this myself where someone performed a bedside fast exam and said there was a pericardial effusion in a trauma patient that needed to go to the OR for sternotomy after a penetrating chest injury. The patient was taken to the operating room. The chest was opened right as the patient was intubated. And then after placing the TEE, you could see there was no pericardial effusion. There was an overconfident provider that made an overcall. The American Society of Echocardiography has also made a statement on point-of-care ultrasound or critical care echocardiography that it should not be used as a rule-out tool because this can lead to missing important findings by either omission or exclusion. It can rule in diagnoses but shouldn't be used to definitively rule them out. If you don't have this in your hospital or you're trying to optimize or grow this in your hospital, what tips can you take from this episode to start working towards implementation of a Rescue TEE hospital-wide system? I want to review 7 key implementation tips when it comes to implementing the use of Rescue TEE during emergencies at your hospital system. The first of which is institutional buy-in. There needs to be data that's accumulated regarding morbidity and mortality to demonstrate the use of Rescue TEE in both shock and cardiac arrest states. And then on the local front, identifying a local champion such as a cardiac anesthesiologist or cardiologist that is TEE certified and can help lead a rollout in this area can be immensely helpful as well. They can help train people that want to use it more and more, and also advocate on behalf of hospital administrators when it comes to needing to purchase more equipment. Number 2, there needs to be training or credentialing pathways to make sure that people are trained and certified appropriately to be able to use this safely. This can involve simulations, mock codes, a basic limited use amount, or an advanced perioperative certification as well. Step number 3 is starting to develop protocols and workflow for how it can be used more efficiently. Having trigger criteria such as refractory hypotension or hypoxemia or cardiac arrest. Defining roles when people arrive for a code situation, such as who's going to place the probe, who's going to interpret the images and do the exam. Will someone be performing documentation at that time? And then having clear cognitive aids that you can use in emergencies, as these have been shown to help us in things that we forget in stressful situations to make sure that we still perform things in a systematic order. Number 4 is evaluating your equipment and access to the equipment. You're going for speed here when it comes to Rescue TEE, so you want to think hard about where you actually store the TEE machine and the probes. In the operating room core, in the cardiac ICU, in emergency department resus bays, wherever it is, you want them to be quickly available to some of the highest risk patients. You also want to have a system for sterilizing your probes and have a rapid reprocessing. Number 5 is education and culture. You want to start having awareness sessions when you bring to the attention of surgeons, intensivists, ED teams that this is a service that is now available at your hospital and even should be expected in certain emergencies. Having M&M conferences can help highlight the impact of TEE as if it was performed during emergencies for some patients. Number 6 is quality and safety monitoring. In every quality improvement project, you need to have a way of evaluating the success of the intervention. So by logging cases by indication, findings, and clinical impact, you can track over time how influential this service is to improving patient care in the hospital, and also assess for outcome linkage. Did this improve patient survival, diagnostic accuracy, time to intervention as well? Then keep in mind for step 7 that this can be a phased rollout. Remember, you want your highest trained individuals to start doing this first. The cardiac trained anesthesiologists who have the most experience with TEE in the perioperative setting. Then you can expand this to ICU and emergency department settings where select intensivists and emergency physicians can use this if they have the training to do so. Finally, you can roll this system out into the entire hospital. Every time there's ACLS, if you make sure a TEE machine, probe, and a credentialed user show up who's available to use it to help guide post-arrest management, this can be of significant benefit to your patients. What are some of the limitations and workflow considerations that you need to keep in mind if you're thinking about having a Rescue TEE system? The usefulness of this system is that it's operator dependent on the level of training. People that have undergone more training and more intensive learning programs oftentimes see more clinical benefit. Probes and equipments are frequently unavailable because they're costly, so keeping them in every operating room is not great resource utilization. However, the more available this equipment can be, oftentimes the more helpful it is. So discussing with hospital administration how to justify the cost based on all these improved clinical outcomes that we have seen in the literature and you may see at your hospital can be something you discuss. Keep in mind that one of the limitations is esophageal or gastric injury risk. Make sure you ask your screening questions whenever you use this, that you don't use it blindly or flippantly, but you're calculated about evaluating the risk versus benefit to your patients. There are no formalized guidelines or certifications for Rescue TEE, so keep keep that in mind, that we be wise about our utilization of it and really decide when it is of greatest clinical benefit to use this until some of these become more apparent. If you work exclusively in an emergency department and you're trying to have people teach you, it's not often you cross paths with experienced cardiologists or cardiac anesthesiologists that can teach you a lot of these techniques. What are the future directions that Rescue TEE could be going? Well, some of the things that are being discussed are AI-assisted view acquisition and interpretation for non-experts to be able to evaluate what's causing the shock for people who don't know how to evaluate the images themselves. Could there be a role for this in pre-hospital and emergency department settings, evaluating the value that it adds to those settings versus the logistics of trying to get the equipment and trained operators in place? Are there certain credentialing pathways that need to be formalized for a Rescue TEE certification, and then waiting for the arrival of formal society guidelines to really shape out how Rescue TEE ought to be used systematically in the perioperative setting? So the major claim that I made in episode 15, the first part of this series, was that the greater the availability of TEE in high-risk hospital settings, the greater the proportional benefit to patients. Did I prove this? Did you watch episode 15 through 17? Let me know in the comments. Let me know what you think. If you think there's more work to be done, if you disagree with me, or if you see just how useful Rescue TEE could be if it were placed in trauma bays, L&D floors, high-risk non-cardiac operating settings. Last time I'll say this, the T-Time Rescue TEE protocol is available for free for you. Just hit the like button, leave a review, and then in the comments, make sure to leave your email address and we'll get this document to you. The next episode, I've gotten multiple requests to do, but it's looking at TEE and medical malpractice. We're going to cover what doctors should know to prevent medical legal complications from TEE and what attorneys and patients should know in the event there were complications related to TEE use. Thank you guys for watching. As always, feel free to hit that subscribe button if you want content to be brought to you as we make it. Also, leave a comment to the show. Let us know what you thought, if there's something you do different in your practice, so we can all learn from each other. But thank you again for watching. We'll see y'all next time.